Hello? Who has loved being in Melbourne?
Yeah.
This is a kick-ass conference, and I mean that in a very good way. You get a conga, you get these amazing speakers. Thank you so much. I'm delighted today to tell you that we have some really wonderful speakers. And I might just go back here. We have Professor Sharon Parish and Professor James Simon. Dr. Sharon Parish is a Professor of Medicine in Clinical Psychiatry and Professor of Clinical Medicine at the Weill Cornell Medical College. She's an attending physician and Director of Medical Services in New York as well. She's done so many amazing things. She's past President of the International Society for the Study of Women's Sexual Health, former Chair of the Clinical Practice Guidelines for the ISSWSH. There's lots of letters in all of these things, aren't there? Past member of the International Society for Sexual Medicine Board of Directors, and has written extensively in this area. She knows this area. It's a great honour to have her. And I'll also introduce Dr. James Simon. I know him as Jim, and I suspect if you go up and call him he would be very happy to meet you. He's a board-certified OB/GYN, for Australians that's a gynecologist and obstetrician, and a reproductive endocrinologist. He serves as clinical professor at George Washington University and has a private practice. He's been awarded with top Washington physicians, America's top O&Gs, super doctors of Washington, and the best doctors in America. Go, Jim! It is with delight that I hand over to Professor Sharon Parish for the first part of our meeting. Thank you so much.
Thank you very much for that introduction, and I can't tell you how honored I am to have the opportunity to speak to you about this topic, and I want to squeeze my brain to show my excitement. So I'm going to be starting off, and then I'll be handing it over to Dr. Simon. I want to start our lecture with the following disclaimer. We're going to use male, female, cisgender pronouns, he, she, and the focus is heterosexual, and it's related to the fact that most of the research and all of the therapeutic options to date for the conditions we're going to be discussing were developed in this context. And the absence of quality research on non-heterosexual and non-binary individuals and populations is of significant concern and does need remediation, so that's a charge. The objectives of our lecture and the discussions we're going to be having start with reviewing the classification, epidemiology, and models of female sexual dysfunction, so there's context, looking at associated factors in the menopausal woman. We're going to examine the efficacy and safety of androgen-1 for generalized acquired hypoactive sexual desire disorder, its indication in postmenopausal women. We'll be discussing clinical indications, appropriate candidates, and target symptoms for treatment with evidence-based transdermal testosterone, this product. We're going to explain the current clinical guidelines and how these practice guidelines regarding preparation, dosing, clinical and laboratory monitoring, and follow-up when prescribing transdermal testosterone for women will inform care to best practices. We'll also explore future directions, which is an area of great interest for many, for use in women. So I'm going to start by giving context about sexual function in sexually active older women. And this is a relatively large US population-based survey study looking at the complaints, and it was part of a larger social health and welfare study. And you can see in the pink that the most commonly reported complaint of 43% was the lack of interest in sex or low desire. These weren't clinically assessed, but this was the most common complaint. And the second most common was inability to achieve orgasm. And if we probably tease that out further, it would probably relate to not getting the arousability level that enabled orgasm. Then we have difficulty lubricating, which isn't technically a sexual dysfunction, was more common than difficulty with arousal, but it was very close to the challenges in desire. And then we have lack of pleasure and pain. And we'll come back to how those interrelate, particularly lubrication difficulties in postmenopausal women and desire. The ISWISH, talking about acronyms, that stands for the International Society for the Study of Women's Sexual Health. And we'll be talking about some of their guidelines and processes of care and how that interrelates to the recommendations we're making here. We have subdivisions across the phases of sexual function. Hypoactive sexual desire disorder, our focus. Female sexual arousal disorder, which has both cognitive and genital components, and a condition called persistent genital arousal disorder. The female orgasmic disorders or difficulties can range in problems with frequency, intensity, timing, and pleasure, and there can even be illness syndromes associated. One of the points I'd like to make about thinking about the context of the indication for prescribing testosterone for distress and low desire is that you understand how that difficulty or dysfunction interrelates to any other presenting symptoms that a woman might have. And learning about what the predominant condition might be and how you address multiple conditions when they're present. But one of the key things I always say to people when I teach is to ask about all phases and identify what's really come first. So now let's turn to hypoactive sexual desire dysfunction, what we're going to be addressing here. The ISWISH 2016 definition in the nomenclature I just showed you of HSDD is that it manifests as any of the following for a minimum of 6 months, and that's been modified to say 3 to 6 months in other literature. This is a lack of motivation for sexual activity as manifested by decreased absent spontaneous desire, and these could be sexual thoughts or fantasies, decreased or absent responsive desire to erotic cues and stimulation, or the inability to maintain desire or interest throughout a sexual experience. Loss of desire to initiate or participate in sexual activity, including behavioral responses such as avoidance, anything that could lead to sexual activity that's not secondary or due to pain, and that might be related to low lubrication. And it has to be, to meet the definition, combined with clinically significant personal distress. And some examples of what's reported in studies include frustration, grief, guilt, incompetence, loss, sadness, sorrow, or worry. And I commonly hear, like, I want it back. I lost that feeling. That's what people sometimes mean by loss. There are specifiers that come from schema, including the ISWISH criteria, the DSM-5, and ICD-11, which is the coding that's currently used here and being adopted by countries worldwide. And these specifiers or subtypes help us make diagnoses, and that's the clinical utility. So we define them by onset. Is it lifelong, or is it acquired, developing after a period of normal functioning? And the importance here is that we want to look to see that it's an acquired disorder when we think about prescribing. Is it generalized, not limited to certain situations, stimulation, situation, or partners, or is it situational? And generalized conditions are generally things we treat with pharmacotherapy. What are the characteristics? What are the interpersonal, psychological, and organic factors? How long has it been going on, and how severe is it? So looking at the prevalence and epidemiology of decreased desire with distress, we see here a large population-based survey study that was done in the United States of approximately 30,000 women. And the prevalence here shows sexual problems associated with related distress, and I explained that was an important part of the definition of HSDD, by 10-year age bands. And any disorders on the top, and you can see the pink bar, desire, is the most common amongst the other two sexual dysfunctions, arousal and orgasm, that are the phase dysfunctions. And in the midlife women, that's the highest peak. And here it's around 10 to 15 or 10 to 12%. If we look at this is unpublished data, but there's also published data that mirrors this. If you look at the prevalence in the pink of low desire across the ages from 20 to 80, we can see that the prevalence of low sexual desire tends to go up, but personal distress kind of stays level or maybe then decreases as women get older. And if we saw a bar across the middle, we would see that the prevalence of HSDD remains relatively constant, and becomes most particularly prevalent or predominant in the Middle Ages. This is a study that was done, E stands for epidemiologic, HSDD, that was done in Australia, looked at Australian women and looked at the likelihood of having HSDD that included both the presence of low desire and distress. And we can see that in the middle-age group, it was in the 30% range, ranging from 30.5 to 33.4. And the likelihood was greater in women who were partnered, sexually inactive, more educated, or taking psychotropic medications. But it didn't look at whether they were effectively treated with psychotropic medications, because the best outcomes for desire have to do with treated depression. The negative effects of menopause can be quite impactful related to vaginal discomfort. We see, and we've heard a lot about it at this conference, we'll continue to hear about it, that in postmenopausal United States women, the effect of vaginal dysfunction is very great in terms of its negative effect on the sex life. And one of the messages we commonly give when we're looking at HSDD is, again, to look at the phase presence of different sexual dysfunctions and how they occur, their timeline. So a very important question to ask is, is your desire related to pain or decreased lubrication? And then if that's the case, of course, you want to fix that first. So there's also the circular incentive-based model, which isn't phase-related. It doesn't speak to the idea that sexual dysfunction, you have desire, or sexual function, you have desire, you get aroused, and then you have an orgasm and you're satisfied. Here, with this alternative or circular incentive-based model, the idea is that spontaneous sexual desire may or may not be at the center of a decision to initiate sexual activity, and that the emotional incentives, desire for intimacy, may motivate a sexually neutral woman to seek out or be receptive to sexual stimuli. And when you're looking at HSDD, it's that circle around those issues that we really address. Does it bother the woman that she doesn't have spontaneous desire? What is her motivation? Is it that she wants to be close, or is it more of a duty situation? She doesn't want to disappoint her partner, or she feels she must. And when she feels distressed about not being able to go from neutrality to enthusiasm or receptivity, that's when you start to inquire as far as whether this is HSDD. So this is the timeline of the identification and diagnosis and the treatment of HSDD. And we see here that the story starts with the guidelines using screeners, which I'll introduce to you, as a screening tool to develop treatment guidance for HSDD. And there was simultaneously developments in the development of androphene starting in 1999. And over time, there were the studies of androphene and the development of clinical guidelines that provide algorithms for assessment and management. And then there were global statements. The global statement from the consensus panel that was published in 2019 really is behind many of the treatment principles that we're sharing today. The global consensus position statement on the use of testosterone in women, Susan Davis was the lead author and many consensus panelists are here. Then there was a meta-analysis that was also done simultaneously with the development of that consensus paper that provides the data we're going to show you. And this is integrated with the ongoing treatment guidelines that are further developed in some of the other future papers. The International Society for the Study of Women's Sexual Health provided a clinical paper, in addition, that really speaks to the nitty-gritty of how you prescribe testosterone. Let's look a little bit at the science behind HSDD and how HSDD affects the brain. So we see here that the brain controls desire differently in women with HSDD, and PET scan studies show that women with sexual desire activate the right brain, and they will also show patterns that show that they're aroused, and that they deactivate the left brain when they are shown erotic stimuli. However, women with HSDD show minimal changes in these areas, showing weaker activation of the right hemisphere and less activation in the left. And the net sum gain is that they don't turn off inhibition and they don't turn on excitation the same way as women who don't have HSDD. And the principles behind therapy seek to change that balance. Another way to look at it is, can we influence inhibitory factors in the brain? The balance of inhibitory and excitatory factors leads to either sexual desire that feels normal or sexual desire that's disordered. So the key to treatment is to modulate these neuromodulators and see if we can shift the balance. In other words, change the seesaw. So pre-treatment, inhibition is overriding excitation in women with HSDD, and post-treatment, we're seeking to shift that seesaw up so that excitation can be enhanced. And if you look at the brain pathways, there are neurotransmitters or neuromodulators that also influence this. If you look at the brain pathways, we'll see in PET scan studies and other research that this leads to activation of areas that are important for sexual desire, such as the medial preoptic area, the MPOA, the ventral tegmental area, the VTA, and the nucleus accumbens, and deactivation of the prefrontal cortex, which leads to less inhibition. The science behind HSDD also is informed by the biopsychosocial model, that there are biological, psychological, interpersonal, and sociocultural factors that inform the female sexual response. If we dive further into contributors of desire, we can see that sex hormones, which are part of the biology of neurotransmitters, et cetera, and other medical conditions, are a piece of the pie, and that's going to be our focus here. Well, we don't have time to talk about all of these interpersonal, intrapsych, and psychological factors today. We want to make you aware that they may be contributors, and you can either investigate them or integrate other types of clinicians who may help you understand their role in the pie. So I want to now introduce one other idea from Ipswich. So we had the nomenclature, and now we're talking about a process of care for the management of hypoactive sexual desire disorder in women. And it gives you a very simple, stepwise, progressive approach to looking at how to identify, diagnose, and treat HSDD, and we'll break down pieces of that model as we go. So we start here with the idea that in order to identify a condition, such as any sexual dysfunction or HSDD, you have to ask permission and bring up the topic. You have to screen and identify that the person has low desire. We'll talk about using a screener to make this diagnosis. Remember, I mentioned earlier that we want to find a generalized condition that's acquired and amenable to treatment, and that we've addressed the biopsychosocial factors that may be important and modifiable prior to considering treatment. So starting with screening, I want to make a few key points. We recommend that you normalize and universalize conversations about sexual health issues in all of your patients. And you can start either with just a direct question, and I often recommend giving sort of an introduction or sort of a warning shot about what you're bringing up, or you can use a ubiquity-style question. Many women after menopause have concerns about their sexual function, have issues around low desire. How about you? And you might want to relate it to a specific condition or a specific treatment that emerges. And then you may want to continue the inquiry by asking about these phases that I've been discussing: desire, pain, what came first, how does this relate to any other difficulty with arousal or orgasm, and then use open-ended invitations to explore further. I highly recommend being explicit first so that you can model the language. Use words like sexual problems, desire, pain with lubrication, and then say, tell me about it. Let me learn more about this and how it affects you and what's its impact, and are you distressed? Because again, that's part of the definition. There is available the decreased sexual desire screener. This has been validated as a quick and effective screener for screening for generalized acquired HSDD. It starts with 4 questions. Was your desire good in the past? Was it satisfying? Has there been a decrease? Are you bothered by it? Would you like to see it increase? And it's specifically designed, again, for the condition of generalized acquired HSDD, and it's intended for practicing clinicians with little or no experience in knowing how to diagnose HSDD. It's dummy-proof. If the patient answers yes to all of the questions 1 through 4, then you look at their answers to question 5, which are self-assessed associated biopsychosocial factors. And it doesn't have to be that they're no, but as you see answers to question 5, if they do say yes, you explore it. And if you don't think that's more significant as an issue to address first, then you move forward with approaching and addressing their HSDD. So modifiable factors, the idea is not that they don't have any, but that they're not the more primary condition. And you, like if somebody's depressed and they're completely untreated, you might address that first. But if their treatment is working, but they happen to be on psychotropics and they still have HSDD, then you go further. So in the process of care, I just want to blow up that piece. You find that they have generalized HSDD. You assess these biopsychosocial factors, and you try to modify them. And if you learn that they're no longer modifiable through education or other interventions, you're dealing with HSDD without remaining modifiable factors. And that's where you begin the discussion about treatment with treatments like androgen and transdermal testosterone. This process of care really speaks to the idea that when you look at testosterone therapy, it should only be initiated after a full biopsychosocial evaluation and appropriate management of other conditions that may contribute to diminished desire. And this may sound like overwhelming, all these biopsychosocial factors, and I'll show you in the next few slides some examples, but it's pretty quick, just like you look at contributing factors and differential diagnoses for many other conditions in your practice. So this is, comes from the paper I've been discussing and others, looking at some of the most important medical conditions that impact sexual function across the phases. When it comes to desire, there are important factors like hypothyroidism, metabolic syndrome, and maybe that interrelates to obesity or self-esteem. Spinal cord injury has a variety of factors, malignancy and its treatment, and we hear some about that here at this meeting, as well as major depression. One comment I'll make, I've mentioned depression a few times, is that when it comes to depression, the most important thing for desire is to not be depressed, however that is, whether it's psychotherapy, office-based counseling, psychotropics, and sometimes treatment-emergent sexual dysfunction related to psychotropics can be addressed as part of a treatment paradigm or treatment approach for HSDD. But it doesn't mean you still don't consider or use testosterone. Medications, some of the most common ones that come up when we're talking about desire include the impact, the absence or presence of hormonal treatments or anti-androgens. I already mentioned psychotropics, and you can see some of the other common heavy hitters on the purple bar on the side of the slide. In terms of modifiable factors impacting sexual function and psychological and interpersonal factors, you can see a list of things here. Now, some of these things are easy to counsel about, stress and distraction, and figure out, like, is it timing, is it stress, is it distraction, can you give some office coaching? And if I had more time, I'd love to talk to you about office coaching for low desire. But some of them require just identifying and saying, you know, this is important. I'm glad you told me about this history of abuse and how you think it's influencing your engagement now and why it's coming up at this time in your life. I'm going to make a referral. And learning to make an effective referral to either treat first or treat collaboratively while you look at the biological factor and perhaps treating using testosterone is an important skill. And this is sort of how I think we should together look at this list when we're approaching pharmacotherapy. When the etiology of generalized acquired HSDD appears to be multifactorial, like we've been discussing, you don't have to have nothing. It's just really an important factor that they have distressing low desire. Without a predominant factor identified, pharmacologic therapy can be considered. And this is an important principle as we transition to the nitty-gritty of using testosterone. However, combination therapy, including psychological and pharmacologic therapy, may be beneficial in all circumstances. I'll transition now to getting into some of the details of another ISWISH guideline that I mentioned earlier on, which is the use of testosterone in women. And some of the key messages related to androgens are that androgens, including testosterone, are essential hormones for the development and maintenance of female sexual anatomy and physiology and the modulation of sexual behavior. Testosterone has many physiologic and pathologic actions in women, and we'll be discussing some beyond just brain and desire a little later on, directly through cell-specific receptor and by non-receptor-mediated actions and by conversion to 5-alpha-DHT and estrogens. There's no serum testosterone that you can use to make a diagnosis as a cut point, but measuring it and looking at its levels and so forth have implications for both associated improvements in sexual function and treatment targets in terms of exceeding certain cut points. We recommend using a total serum testosterone as the best practical assay. These are sort of the bottom line points about androgens themselves, and now we'll explore these in greater depth with Dr. Simon's presentation. Thank you.
So much.
Hello. So many of you are now cringing because you know that the chicken wire diagrams are coming next. This is a simplification demonstrating where testosterone and other androgens come from in women. And just as a point of reference, we talk about estradiol as being the female estrogen of reproductive aged women. Well, androgens, as listed for you here, DHEA and its sulfate, androstenedione, and testosterone, the major androgens in women, are present in 10, 100, or 1,000,000-fold greater concentrations than estradiol. So to say a woman's hormone is estradiol and to say that androgens or testosterone are men's hormones is, in a word, bullshit. Maybe that's 2 words. My point exactly. Women have bucket loads of androgens, including testosterone, and they emerge from 2 primary sources: the adrenal gland and the ovary. And obviously, if women have oophorectomy as part of a treatment, a huge source of their androgens, some 50% or so, is gone. We don't usually take out adrenal glands, but they can be suppressed by steroids and other inflammatory treatments. And we also have peripheral conversion of precursors, androgenic precursors, to active testosterone and other androgens. So fat is important in androgen production, and fat is critical to reproduction. Every clinician in here knows of a woman who's too thin and has too little body fat to menstruate. This is a part and parcel of how we get to androgens, desire for sex, with Mother Nature's primary purpose of reproduction, but obviously in a menopausal context, desire for sex is independent of reproduction. We pretend. So here's the steroid pathway, and my purpose in showing it to you is not magic. It is to emphasize that testosterone, shown here in my little circle, can be converted to both estradiol and dihydrotestosterone by existing enzymatic machinery present in every woman to one degree or another. This has been a problem in doing research because if you give testosterone to women, its actions may be mediated through testosterone and its receptor, which I'll show you in just a moment, or they may be mediated through conversion of testosterone to estradiol or other androgens or estrogens. This is critical because in the human brain, and by the way, in nearly all mammalian brains, estradiol and testosterone receptors are located in similar locations, if not on the same cells. So is testosterone acting as testosterone? Is it acting like estrogen? Is it acting like a little of each? And by the way, men and women have very similar distributions of these 2 receptors. So maybe we're not all that different. Circulating androgen levels and sexual function. Well, first of all, androgens in women, as I mentioned, are easily converted to a variety of other active steroids. So that measurement of serum testosterone does not really provide any specific measure of androgen exposure or action in a particular tissue. And at present, we don't have a way to measure, at least in a clinical sense, intracellular levels of testosterone, which would be great because then we could actually target the receptors and the cells in question to answer these fundamental questions. Unfortunately, also, I'm yet to find the patient who's willing to have those brain biopsies for me to find out what their testosterone levels are in their sexual parts of their brain. So we have many barriers to really understanding sexual function as it relates to these hormones. Finally, there are many disorders of androgen receptors in men and in women. I won't go into them, but the two that jump to mind, one in men and one in women, hypospadias and other minor deformities or major deformities of androgen sensitivity are pretty common. My guess is that many of you have had young boys or grandchildren, boy-grandchildren, who have been born with some element of androgen insufficiency as illustrated by an anatomic problem. In women, we have vulvar vestibulodynia, an acquired hormone-mediated type. I know those are a lot of words. And that dysfunction in both early premenopausal women and postmenopausal women is thought to be due to an abnormality in the androgen receptor where it's less sensitive to androgens than in normal women. And just this illustration helps describe in a nutshell how that androgen receptor mechanism and non-receptor mediated mechanisms all lead to our final clinical endpoints. For example, the androgen receptor going through the normal receptor-mediated processes enter cells that are sensitive. You get gene transcription, translation, protein production, and trophic or functional effects in the bladder, urethra, brain, genital tissues, heart, muscles, ligaments, etc. But we also have a growing knowledge of non-androgen receptor, non-genomic signaling leading to similar endpoints. So it's complicated, but not clinically complicated. You don't need to know exactly how it's working in your patient, just whether it works or it doesn't. Making a proper diagnosis, as Dr. Parish told you, it's not that complicated. Ask permission, administer the screening test, follow the yes-no diagram. It's not more difficult than that. Well, what target testosterone levels are we suggesting that we look at or approach? And here is another simple answer. We are trying in our postmenopausal women to repeat their normal premenopausal levels of total testosterone. I'm going to say it one more time. We're trying to reproduce their normal premenopausal levels of total testosterone. That's the target. Not bodybuilder levels, not something that's going to make those otherwise normal women look just like me, bald and bearded. My wife tells me it's a really good look on me, but not a good look on my female patients. You get the point. And here are the levels. For those of you who are familiar with nanograms per deciliter, here are the levels as they change from the 20s, the 30s, and the premenopausal levels in the 40s. For those of you who are more familiar with international levels, here they are in this row of numbers. And we can demonstrate, and with a bow of appreciation to our chairperson, Dr. Davison, who published this fantastic study a few years ago demonstrating the reduction in androgens as we age from here at age 18 to 24 to here at age 65 to 75. So I don't want to ruin your day, but it's been downhill since age 18. And other androgen precursors that follow this similar pattern. Historically, we've thought that this fall in testosterone over the lifetime had a change in later years, here shown between 60 and 80 years, what I call the hockey stick of testosterone levels. But we're now seeing more clearly that rather than a hockey stick, it's more like a plateau and a flattening, but still difficult to explain why this trend downward stops going downward as we age further. And those of you who know people who are much older, even older than I am, know that older adults, both men and women, can remain sexually active even into their 80s and 90s. So let's talk about how we associate testosterone levels and the female sexual dysfunction diagnosis and treatment. And as Dr. Parish noted, there is no cutoff in blood level that you can measure that makes the diagnosis of HSDD or differentiates normal women from women with HSDD. And there are a number of reasons for that, but there is no direct correlation. In our clinical practice guideline, while there's no testosterone correlation that makes that presence or absence of HSDD possible, there's a loose correlation between testosterone concentrations while undergoing treatment and their benefits. And I'll bring this up again when I show you future directions and how too much of a good thing can be an issue. But in general, within the normal reproductive age range, the more, the better for women. So the main reason to measure testosterone is largely to exclude women who have plenty to begin with, namely women whose values of total testosterone are in the mid-range to the higher levels. Even though they may have low sexual desire, it is unlikely that raising them a little bit more, but still staying within the normal range, it's unlikely that it will help them. And the other reason to monitor is to avoid overdosing them with the ultimate problem of ending up looking like me or having other side effects. So avoid supraphysiologic values. In the process of care, before starting testosterone therapy, there's a need to know what those modifiable biopsychosocial factors are and that they've either been treated or in the process of treatment. And while I'll talk to you about perimenopausal women, there is literally no information to suggest that giving more testosterone to premenopausal women who are normally ovulating, demonstrating normal levels of testosterone, there's no demonstration that adding more will help. We here, this is the International Menopause Society, are focused on these postmenopausal women. Now, depending upon where you are in the world, you may have other treatments that are approved by your regulators or used off-label in place of or instead of testosterone. And while our focus here is testosterone, and in particular, the unique benefit of being an Australian, living down under, you actually have a regulatory approved testosterone product for women, something that is unique as far as I know in the world, that no one else has it, at least at present. We hope that changes for the benefit of all of us and our patients. But there are also other therapies. These are all non-hormonal therapies. Bremelanotide, which is a subcutaneous injection, PT141, if you're an internet YouTuber or a YouTube viewer, and it acts through the melanocortin-4 receptor to increase DA, which is dopamine, my absolute favorite hormone. Flibanserin, which is available in the US and Canada, which is a mixed serotonin agonist-antagonist, and while most of you, if not all of you, think serotonin is one thing because we give SSRIs for depression, the answer is there are currently identified 9 families of serotonin receptors, and there are 3 different members of each of those families or more, so there's a lot of different serotonin receptors, and while antidepressants typically have significant adverse effects on sexual desire and orgasm, some serotonin modulation, like with flibanserin, does increase sexual desire through different signaling pathways involving the serotonin system, ultimately decreasing that same amount or same type of serotonin adverse effect that we get with SSRIs. 2 medical treatments used primarily in depression and anxiety and often confused by their name, buspirone, brand name Buspar, and bupropion, an antidepressant and anti-anxiety agent, are used for the treatment of low sexual desire as well, and they work by increasing dopamine in the central nervous system. So let's go back to the process of care and look at the overview that we've laid between Dr. Parish and I. We've laid the groundwork for. So first, you're going to discuss sexual function with your patients. Everybody can do it differently. Do it in a way that's familiar and comfortable for you. For me, I ask everyone on every occasion. Dr. Simon, I have a yeast infection. I ask everyone every single time, are you having any issues with your breasts, your bowels, your bladder, or your sex life? If I don't ask, sometimes I've got my hand on the doorknob on my way out of the office because I'm in a hurry. Dr. Simon, aren't you going to ask me about my breasts, my bowels, my bladder, and my sex life? So thereby, as a male gynecologist, I've completely made this a neutral, non-threatening part of my patient interaction, and I think it works well for me. We do screening, and the Decreased Sexual Desire Screener is a validated instrument. Your patient can do it yourself, or your office staff can help. It takes 1 minute, maybe less, to do, and you just need to review it. We talked about the labs, what to measure and when. We'll talk lots more about AndroFem, its efficacy, and monitoring follow-up to initiation of that treatment. We want you to use total testosterone as opposed to something more complicated or difficult. This is a conscious choice that's available to almost all individuals, and if available, we want you to use a much more sensitive type of assay, liquid or gas chromatography, and associated tandem mass spectrometry. That is not the assay used in most tests. If you just say, I got a testosterone honor. That's a dirty test for women, developed primarily for men, and because men have a lot more testosterone for women, that dirty test works just fine for men, but is complete, again, two words, bullshit, for women. If you want to play darts, don't do it with your eyes closed. Do the right test and get the best information, and you need to use tandem MESPAC and some kind of chromatography to do it. Best to spend the money or the patient's money because you're otherwise flying blind. Those direct assays just don't work, and they could be used for excluding very high excessive levels, but not for monitoring testosterone or diagnosing it, HSDD, in any way, shape, or form. One of my pet peeves is the sex hormone binding globulin. It's an alpha-2 globulin of liver origin, goes up when you give oral estrogens, no effect when you give transdermal estrogens, and it binds up a whole boatload of testosterone. And not infrequently, we inadvertently raise it so high that our patients have no hot flashes, no night sweats, no menstrual cycles, and yet no interest in sex. My favorite paradigm is the polycystic ovary patient, who does look a little like me, and where we want to decrease her androgen burden, and we clear up her skin, and we clear up her excess hair, and we give her regular menstrual cycles, but now we've decreased her testosterone so much she doesn't want to have any sex or go out. So we need to keep some balance, and very high levels of SHB, as I've just indicated, lower testosterone and make any treatment of testosterone more difficult and less efficacious, and very low levels of SHBG, which do occur in women just by happenstance, can cause excess side effects even when hormone levels of total testosterone are in the normal range. So as it relates to baseline laboratory interpretation, get that SHBG when you measure her total testosterone. Use this process to determine whether she's basically normal or falls into the excessive high or excessive low range, and then start her on treatment and follow up as we will discuss. What's the range you're trying to hit with testosterone treatment? Let me remind you, we're focused on the normal premenopausal range, as indicated for you here. Now, Lawley's product, Androfem, and I would argue, based on my clinical experience, you can push the levels higher than the normal range. I wouldn't do it on purpose, but if you found it to be effective for that patient, you can get away with increase, including 50% above the normal premenopausal range without side effects. I'm going to say that one more time because it's a critical point. All drug delivery systems are imperfect and have variability, and if you just happen to check her testosterone level and it's a third above the normal range or less than 50% but above the normal range, it's still fine unless she's having side effects, in which case you lower the dose and adjust. So testosterone in women, does it work for sex? That's why we're here. Well, there's more than 46 reports, 36 randomized controlled trials involving almost 8,500 participants, both naturally and surgically menopausal, with HSDD, with or without concurrent estrogen therapy, with or without transdermal or oral therapy. And in those studies, as a brief take-home message, testosterone significantly increased sexual function, including sexual events, sexual desire, sexual arousal, orgasm, pleasure, sexual responsiveness, and my absolute favorite, sexual self-image. You can improve a woman's sexual self-image by giving her testosterone. I want you to just think about that for a second. All by reducing sexually related distress. I'm going to test you on each one of these in about a minute, but the answer is all of them show an either no effect or a significant increase in the endpoints related to sexual desire in postmenopausal women with or without estrogen, oral or transdermal. And it's quite a universal phenomenon. Distress, which Dr. Parish noted for you is important in making the diagnosis of HSDD, was significantly and concomitantly reduced significantly in this treatment. So testosterone improves sexual functioning and decreases sexually related distress. That's a home run or a goal. Who to treat? Candidates are postmenopausal women who have declining sexual interest, associated distress, who follow the buckets in the ISHWISH process of care or consensus guidelines, and who do not have other reasons for having low sexual desire and distress. The patient that doesn't want to have sex with her husband because she doesn't like him anymore does not have HSDD. This is also particularly important in women with premature ovarian insufficiency because not only do they need their hormones replaced, their estrogen and their progesterone, but they need their androgens replaced also. The new diagnosis in the DSM-5, female sexual interest and arousal disorder, has not been investigated as it relates to testosterone, and ISHWISH doesn't recognize this diagnosis. So, who's eligible? Postmenopausal women on hormone therapy who are single or combined therapy with HSDD, postmenopausal women not using menopausal hormone therapy, either combined with or without HSDD, primary ovarian insufficiency or premature ovarian failure who have HSDD, total testosterone levels that are low or abnormally low, and there's no upper age limit. In fact, as I get older, the upper age limit keeps going up. High-level athletes need to be aware of rules for their participation in elite sports because androgen supplementation could disqualify them, even though androfem is naturally occurring testosterone. And those with pre-existing cardiac, hepatic, and renal diseases should be monitored, although I've never actually seen patients have an adverse effect in those settings. So the actual contraindication for androfem: active breast cancer, hormone-dependent neoplasms, etc. Women of reproductive age who are pregnant, that's not happening. Lactating, that's not happening. Children under the age of 18, and those with general contraindications for hormone replacement unless those indications have been evaluated and treated. So testosterone is safe. Women have it all their lives. Men have it all their lives. It's just a question of amount and goal in treating an actual disorder, HSDD, with distress. The transdermal route of administration avoids first-pass liver effects, as it does with estrogen, and testosterone does not appear to stimulate the endometrium, so monitoring the endometrium or providing progesterone without, in women who are only using testosterone without estrogen may be unnecessary, But remember what I showed you, that testosterone can be converted to estrogen, so just be forewarned. As it relates to testosterone, it should be used with caution in women at risk for breast cancer, I didn't say with breast cancer, but at risk for it, and those with cardiovascular disease where there's need. What's much more important and much more common are these unusual but well-known androgenic side effects: acne, increased hair growth, alopecia, and voice changes. I'll say parenthetically that if you have a professional soprano who is menopausal, which by the way is a very rare condition, most of them by the time they get to be menopausal age can't sing in those upper registers anyway, but be careful about giving them testosterone as it may change the character of their voice. So I'm going to bring Dr. Parish back to the podium to tell you exactly how to use the product, and then we'll end up with some future directions and conclusions.
Thank you. Thank you. That was terrific. So we're going to now talk very practically about using Androfem and prescribing Androfem. And so you can see there's a pink tube, not to be confused with the blue tube, and there's a syringe. And I understand there's some mixed feelings about the syringe, but I really want to emphasize that it's much better than what we have everywhere else around the world. You have a standardized product that's government approved, that allows a fixed delivery system that can be measured and gives consistent and reliable levels that you can count on. And I think although we see that there may be a pump pack coming in the future, or we hear this, this is a very good thing that we can use this syringe and provide doses. Other places in the world, people do things like use male products in little silver packets or tubes, or they compound it, and they run into the difficulty of finding the right dose, getting to that appropriate 1/10 of the male dose, or we're trying to approximate the daily premenopausal production rate of 300 micrograms a day. That's difficult to achieve. This is much more careful and specific. So you start with 0.5 mLs, which is 5 milligrams daily, that you open the tube, you squeeze it into the syringe, and the maximum dose you can go up to, and you follow the levels as we explained, and I'll show you again, is 1 ml or 10 milligrams. And you titrate up and down by 0.25 ml increments, and the pack size is a 50 ml tube, so you get 100 days if you start by using 0.5 mLs daily. You can place it on the outer thigh or the buttock, and there's very little concern about transference, but that's a good place to put it if little kids are hugging, etc. So let's look at this kind of in the scheme of the whole thing. So you start, practically speaking, with the blood work. You start with the evaluations. You measure SHBG and total testosterone. While we told you about the superior test, direct assays can be useful for measuring high baseline or high treatment levels and excluding those. You're going to modify the dose and think about the safety as well as the efficacy and assess for androgenic side effects. At 3 to 6 weeks, you're going to see what those levels are, particularly the total testosterone, and go up and down by 0.25 ml increments. And then what do you expect? I actually want to make a comment about SHBG because this is an area for confusion. So I know we said that it's the total testosterone you measure, and we showed this very beautiful, elegant schema about how testosterone acts intrachronologically and through a variety of mechanisms. And it's not really, you can't say it's the free T that really goes in and out of the cells and influences sexual desire. That said, a very high HCBG, which decreases the effective free T, may influence the ability for that testosterone to really act in some ways in the patient. So you can't override a high SHBG and a low free T and then give them a very high total T to overcompensate for that, because that's not safe. Then you have to use a different strategy for dealing with that woman's HSDD, either bring down her SHBG or come up with another plan. So anyway, at 4 to 8 weeks, we're looking for improvements, and that's where we tend to see it, 1 to 2 months, when you're in the physiologic range for premenopausal women. If at 12 weeks you're not seeing this, there's discouragement, it's not working with persistent symptoms, you may either increase the dose and go on for a 6-month trial or reassess. So it's essential to maintain and continue. So we're at 12 weeks, We're at the upper range for premenopausal women. We've gone up and down to the 1L max dose, and then we continue for a 6-month trial. At 6 months, and then again at the outer range of the safety data that we really have available in RCTs, we look to see how is the patient doing. Is the total testosterone being maintained at target, or is it going greater than 50% above the premenopausal limit? And we're looking again at the 6 months and 24 months, whether we stay the course, we change the dose, et cetera. Once we hit that several-year mark, it's really 1 to 2 years. It's really an informed consent process with the patient. We didn't explicitly state this earlier, but we don't have, beyond extension trial data, really RCT data looking at safety and efficacy. But what we find, and we can talk more about this in the Q&A about our clinical experience, is that women really want to continue because it's helpful. And in the absence of contraindications and androgenic side effects and being maintained in the appropriate doses, women do well. And we do need more long-term data, but this is, again, a shared decision-making and informed consent to continue therapy conversation. So what about sort of the clinical monitoring, the practicality? While there's no really specific guidance on this, in the ISWISH paper and other guidance, the Clinical Global Position Statement, we recommend what makes clinical sense for women on hormonal therapy. Annual breast and pelvic exams, annual mammogram, or depending on the guidance in your country about how often to do breast cancer screening. You look for the things that are concerning about androgenic excess. Evaluation for abnormal bleeding, especially if they're on concomitant estrogen therapy. Looking for the things that can occur even, and Jim implied this, but it can occur even, Dr. Simon applied this, even in the therapeutic range. Evaluation for acne, hirsutism. Androgenic alopecia tends to be seen with higher levels or excess levels. Voice changes and clitoromegaly, again, with excess levels. It, again, isn't clear that we really see impacts when you're in the right range with the liver and lipids and cardiovascular markers. We still recommend that they're obtained and monitored based on clinical sense. So lipid profile, LFTs, CBCs can be obtained at baseline, 6 months, and annually. So what are some other treatment considerations? Compounded bioidentical testosterone therapy cannot be recommended. And specifically here, you have a government-approved product. This becomes more challenging everywhere else in the world. But the issue is the lack of evidence for efficacy and safety, consistency of levels. And if you do decide to proceed with the compounded product, the compounding pharmacy should be compliant with purity of active pharmaceutical ingredients and good manufacturing practices to meet industry standards for quality and safety. And in places other than Australia that an approved female formulation is not available, 1/10 of a standard male dose of 1% transdermal testosterone, or a dose that intends to achieve the physiologic range in premenopausal women of 300 micrograms a day, can usually achieve this blood level and the effective treatment outcomes. Compounded testosterone, as we mentioned, and then other delivery systems, such as either in pharmaceutical products or in compounded products of pellets, IM injections, and oral formulations are not recommended due to their supraphysiologic ranges that often occur with their use, and the lack of data showing that these are appropriate treatment, can provide appropriate treatment levels and appropriate treatment outcomes. Systemic DHEA is not associated in randomized trials with significant improvement in libido or sexual function in postmenopausal women with normal adrenal function is not recommended for women with HSDD. In the absence of vulvovaginal atrophy, vaginal DHEA has not been tested specifically for improving HSDD and thus cannot be recommended. And the caveat that I've mentioned in a few different ways is that if sexual pain and genital urinary symptoms or syndrome of menopause is the cause for the low desire, this may be one of the choices that you make to improve that condition and have a forward feed effect on improving desire when they're out of pain. And I'll turn back to Dr. Simon to talk to us about future directions for testosterone use in women.
So before we go to Q&A, I wanted to both respond to Dr. Davis's elegant lecture the other day, and also tell you a little bit about where things might be going for testosterone treatment in the future. So testosterone has action and receptors literally everywhere in the human male and, as indicated here, female body. And recognize that very little randomized, prospective, placebo-controlled clinical research has been done on these endpoints. We're largely, in this next section of my lecture, talking specifically about future directions where some preliminary data or suggestions would bring us to think, that might be good. Let's try it for that. But without data. I want to make sure everyone knows that I'm not trying to convince you that this is how you should use testosterone. But maybe in the future, we'll have data on these endpoints. I'm going to talk about the bone, urogenital system, aside from what we've talked about, arousal symptoms, cognitive function, mood symptoms, and a little bit about muscle and body composition. So Dr. Davis has done a study in perimenopausal women. Perimenopausal women. These women were in their late 40s, regularly menstruating, and the question is, well, does testosterone work for them? And the answer is, yes, it does, but it's not indicated as a regulatory issue for these women. It did increase sexual interest, sexual activity, sexual life satisfaction, sexual pleasure, sexual fantasy, orgasm, and the importance of sex in those women's lives. And they were using testosterone cream 10 milligrams per day, or the higher dose of androfen that we've been discussing. So there is a little data, I would call it preliminary, on the use of this product in late premenopausal women or perimenopausal women. I want to talk about the vestibule. Well, the vulvar vestibule is a very unique tissue. I think Mother Nature made a mistake there, but you never criticize Mother Nature. What we, or sometimes our patients, call the vagina is really three separate tissues. The barrel of the vagina, the wrinkly part, is derived from mesoderm in the early embryo. And mesoderm is also the source of muscles, bone, cartilage, and joints, very tough tissues. Those of you who deliver babies or delivered babies have seen 10-pound babies with huge heads come through that part of the vagina, and it just stretches and goes back. That's tough. The vulva is skin. It's derived from ectoderm, and ectoderm is also the source of nails, tooth enamel, hooves if you're a four-legged animal. It's also very tough stuff. And it tears. It does not stretch when that baby's head comes through. It tears. The vestibule, however, is derived from endoderm. Endoderm is the equivalent of the male penile urethra. And that is not tough stuff at all. It's the same tissue that lines the intestines, bladder, the stomach, the lungs, the liver, the pancreas, very sensitive tissues that have no business being exposed to the outside world, and particularly no business with stretching, aggressive sexual activity. But Mother Nature put it there, and it's an androgen-dependent piece of tissue. So the question is, will the availability of testosterone improve those tissues in women that have one of those receptor pleomorphisms and androgen deficiency of the vestibule, what we call vulvar vestibulodynia in menopausal women. And there are two papers, one on the clinical endpoints on the use of androgens for the vestibule, and one on the basic research aspects of this in the literature. Now, weight gain and body mass changes during the menopausal transition are the bane of every one of our existence because they are associated with all kinds of health problems, as well as changes in body image that adversely affect women's sexual self-image in many cultures. It doesn't start with the last menstrual period. This is data from Greendale from the SWAN study, which began early in the menopausal transition. It's longitudinal data, so these are women of multiple different cultures and ethnic backgrounds in the US and its different states. There are whites, blacks, Hispanics, and Asians, each charted, and in this particular cut of the data, they're all lumped together, but there are individual data sets for each of those groups. But here you see at the 0 time point, the last menstrual period. And you can see that body weight begins to change as early as the study began, 8 years before the last menstrual period. So it's not menopause, but it's that menopausal transition, and it isn't until 4 or 5 years after the last menstrual period that even the trajectory slows down. Fat mass is a big part of that transition. Lean mass actually increases slightly just before the menopause and then decreases. I'm going to say that one more time because it's not obvious. Lean muscle mass actually increases slightly prior to the menopause, the last menstrual period, and then either plateaus or decreases. But after 2 years of menopause, the rate of fat gain, much of it truncal and visceral, doubles, and lean mass begins to decrease. Might the use of testosterone change that balance? I've already shown you that strength and sex peak at around age 18, so I'm sorry for anyone who's here over the age of 18. But muscle mass peaks a little later, around age 30, after which it is downhill for both men and women. Fat mass is highest in women around age 50, and men it continues to rise up until and peaks at around 75. Hormone therapy in menopausal women, which may depend upon type, has been shown to decrease age-associated muscle loss. So if you need another reason to give menopausal hormone therapy, here is one. Those are non-hormonal, non-testosterone hormone increases in skeletal muscle synthesis if exercise is also applied. So get out of your chair and go run. Body compositions are dramatically changed as body composition results in loss of bone, increase in osteoporosis, increase in fracture risk, fragility, etc. And this can be measured in a variety of ways, but I'll just show you the picture. This is skeletal bone composition by trabecular bone score. It's relatively flat, starts to go down about 2 or 3 years before the last menstrual period, and I hate to say it, it's pretty progressively downward without treatment. But curiously, testosterone, in fact, is a better predictor of these changes in total body fat, cardiovascular risk, than estradiol. So might we use testosterone to mitigate some of these obvious adverse changes in body composition, and in particular, maintenance of lean muscle mass? Well, there is some data. It's not primary data. It's secondary analysis of lean muscle mass. Again, here from Dr. Davis's group, it is clearly preliminary because it came from sources that were focused on other endpoints, not purposefully or primarily on lean muscle mass. But there are at least a half a dozen randomized trials showing preservation of lean muscle mass with testosterone. We've all seen that little old lady or that little old man with spindly legs and the beginnings of sarcopenia. Might we be able to prevent it with testosterone? This just recently published and available only online, not in print yet, from Louise Newson's group in the UK, looked at the impact in a clinical sample. This was not a clinical trial. This is a clinical sample of individuals given testosterone and assessed for changes in their mood and cognitive symptoms. Here's the list. There was an improvement in feelings of being tired or lacking in energy, improvement in memory, improvement in difficulty concentrating, an improvement in feeling less tense, less irritable, feeling unhappy or depressed, less interest in most things, and reduction in anxiety and panic, crying spells, and obviously loss of interest in sex. And each of these endpoints show a significant improvement in those endpoints compared to baseline. But take this panoply of benefits with a grain of salt, because for most of them, placebo also has an impact. And is this a real placebo effect? Is it a testosterone effect? We don't know, but clearly all of these benefits are in the right direction and in need of additional research to answer that question. Before we go to Q&A, I just wanted to say, could testosterone be too much of a good thing? Dr. Parish and I have talked to you about its use and documented benefit in HSDD, the primary focus of this discussion. But testosterone has a lot of other effects, as I've indicated. And we're recommending people use testosterone in the normal reproductive age range up to and including 50% above the upper limit of the normal reproductive range, but not more than that. And why not more than that? Why not just go for it? Well, it doesn't work. Or it doesn't work for sex. And now my clicker died.
I'm gonna die your clicker.
It's just one more slide.
Okay.
Can
we have an advancement of the slide, please?
There we go. So if you look in men, very simply, the more testosterone, the better sex drive. But women are not small men. And if you get above the range that Dr. Parish recommended, you actually get a decrease in sexual desire. So if you give too much testosterone rather than an increase in sex, you lose it. And that's been shown now in other endpoints as well for desire, arousal, sexual concerns, responsiveness, and self-image, which all go up to the normal range and then down with too much. So in summary, let me just finish by saying Transdermal testosterone is moderately effective for HSDD in late reproductive and postmenopausal women. Start Androfem 1% testosterone cream at this daily dose of 5 milligrams. Titrate up slowly to a higher dose as needed. Maintain total testosterone in the physiologic range or slightly above. We don't recommend compounded pellets, IM injections, or other formulations. And if an approved formulation is not available, 1/10 of the standard male dose of 1% testosterone can be considered for use, and future directions will likely address some of these other endpoints. So with that, I'll thank you for your kind attention and appreciate any questions you may have.
Such brilliant speakers. We're so blessed, and thank you so much for your insights and your incredible work in this area. It's really important to have an approach in this area. Your patients may go onto the internet. There's lots of cowboy experts out there who'll tell them to use testosterone. They will get it from the internet and they will not be safe. So you need an approach. I'm going to take questions now. We'll start from here, I believe, or here. We'll go here because I looked there first.
I'm Helen, a pain physician. I've been thinking about this question since Sue's plenary lecture on Saturday. Really interested in that hockey stick. So what's your sort of theory about why the testosterone is increasing later in life when the adrenals kick in, but we're seeing those low testosterone consequences?
I'm going to kick in there. Remember, FSH and LH go up around the time of menopause. I think it's the sustained effects of LH bombarding us and the diminishing effects of FSH over time. So I believe, no data here, that the sustained LH just actually makes that testosterone kick up at the end.
Okay, thank you.
I'll go over here now.
I think it also speaks to the idea that it's not the only thing, right? I mean, that's kind of the implication, is that there's a lot of things that...
Might need a microphone.
Am I on? I don't know if you can hear me.
For here.
Are you hearing me in the back?
Yeah, that's
It's
good
on.
now.
Okay, that it's not the only thing, right, that
Yep.
may have an influence on desire in older individuals. And also you have to look at distress, right? And it's complicated. But I wouldn't hang too much of your hat on the hockey stick. In fact, we're seeing that, that newer data suggests it just levels off.
We'll go over to the right here now.
Callum Feely, GP from Moree. And apologies if I missed this part, I came a bit later. It's a two-pronged question with respect to FSH and estradiol measured levels when using this at physiological levels. Number one, when we're using the testosterone, do we actually see a measurable drop in FSH, either directly due to rising testosterone or indirectly through metabolism to estradiol?
So I think that there are some studies that would suggest your contention that testosterone is just a precursor of added estradiol in certain tissues may be correct, but there are other investigations using non-aromatizable forms of testosterone or aromatase inhibitors to prevent that conversion that would suggest that in other studies or other tissues, it's actually a testosterone effect. But clinically, I don't think it matters. If it helps, it helps.
I'm with you. Go over to here.
Oh, sorry, the reason I ask is, we invariably find ourselves occasionally measuring estradiol levels and FSH at the same time when we're in doubt. And when you're using testosterone as well, I just wondered if it had a bearing on either of those levels that confounded them.
From my PhD, measuring sex steroid physiology in over 1,423 women, no.
Thank you.
I'm going over to this side.
Thank you. Jeffrey Otten's my name. I'm a gynaecologist in New South Wales. The question being, a number of women, good proportion of them, struggle with androgenic progestins. I'm interested in your experience. Do they suffer with sometimes similar things with testosterone replacement?
I'm going to address this a little bit differently. So one thing is that a solution to dealing with difficulty with androgenic progestins is not to like sort of then figure out how to overlay with testosterone. You're asking, I think, a slightly different question. But I don't think that we have comparisons between the two, right? To say, is that a predictive factor in terms of how they're going to do
what I'm asking.
with progestins? Right. I don't think we know. I think you have to go forward. Dr. Simon can comment further.
Yeah, so progestins are really challenging in some individuals. They cause depression, anxiety, other mood changes, whereas many women have no symptoms of them at all. And I do not have a solution for androgenic progestins side effects in those individuals except to try and find an alternative, including progesterone, which may be totally different.
I accept that, but my question was, is there a crossover with testosterone? And
No,
do you
I
have
don't
to
think you see
warn
the
them?
same thing. The answer.
I don't think so
It's
either.
certainly worth trying in an individual patient. I
Thank
don't
you.
expect you'll see that in that patient.
I would say no.
We're going to go over to this side now.
Robin Blake, I'm a GP in New Zealand. Just was interested in when you've got women on testosterone, you said to do annual mammograms. So I'm not sure if that's what is normal in the US. Like in New Zealand, we do mammograms every 2 years. Is there an increased risk of breast cancer in women with testosterone that we need to be monitoring them more frequently?
So, I mean, breast density did not go up, and there was an increase in breast cancer risk in women in the trials who were in the physiologic range that we're suggesting. Again, we don't have safety data in randomized trials beyond 24 weeks.
So I think I have the
24
longest study,
There's
not
an extension trial.
extension trial. It's 4 years of data with no significant increase in breast cancer risk above what would have been expected just by being 4 years older. Remember, one of the number one risks for breast cancer is age.
And then there was the Libigel data where they looked at the safety in women loaded for risk factors, and in many 7,000 person years, you didn't see an increased risk.
I just want to highlight that there's a brilliant consensus statement on testosterone use in women. One of the authors of that, the key author, is lined up for the microphone, so we'll get there, I hope, but he did an amazing job. It's a beautiful consensus statement. It looks at the adverse effects, which are really minimal, and it also looks at those safety aspects such as breast cancer, and they did not find those risks over time. So amazing author here, but I'm going to go to this question first.
Hello, Tasha Bashir from Adelaide, Australia. I'm a gynecologist. I do lots of bilateral oophorectomies on women concerned about ovarian cancer, etc. You put a diagram through about 50% of our testosterone comes from ovaries, 50% from the adrenal. So if we take away the ovaries, is there that feedback system of increasing testosterone back to baseline, or are we halving testosterone?
It doesn't go back to baseline.
Even postmenopausally, when you remove the ovaries, there's a 50% reduction in androgen levels.
Okay. And my other quick question, we used to say with Androfem there were 30% non-responders. Is that still the case?
There's a huge placebo effect. I love a placebo effect. What the important thing is here is to do it for at least 3 months, because within that time period you'll know if there's an effect. That's my clinical perspective.
I mean, the response rate is over placebo is substantial. I think that they're always non-responders. I want to go back to the point you're making about women who are oophorectomized. So there is data on this, the WISHES trial, or there are data. So women who are oophorectomized as a premenopausal woman have substantially higher rates, about double the rates of age-matched controls for HSDD in post. And women who are oophorectomized at a postmenopausal range still have higher rates of HSDD than naturally menopausal women. So removing the endogenous source of some testosterone at a postmenopausal age still has an impact on HSDD. And those are particular candidates that we recommend targeting for testosterone therapy in both the global position statement and in their Swiss guidelines, because they're more vulnerable and they're more likely to have biologic components to their HSDD based on the available evaluations of HSDD frequency. So those are important candidates. And as are women, as Dr. Simon mentioned, with POI. They should be managed like any other woman who's postmenopausal, even if it's not a surgical menopause.
Thank you.
Sure. I'll go over to this side now.
Hi, I got myself a little muddled with the reference ranges of total testosterone, so we're aiming for physiological premenopausal levels. When we get a result from the lab, if I've got a 56-year-old lady, the range the lab provides, I assume it's the range for that 56-year-old lady. So how do we know what the premenopausal range is? Do we need to keep a table separately, or how do we know?
From an Australian perspective, you can ring the biochemist from that lab. We're very lucky in Melbourne. We have 2 labs, and I can talk to you later about this, that do a sensitive total testosterone. Even though it's not LCMS, we can have access, and that is an assay that could be used in children, so it's a bit more sensitive. So I think talk to your biochemist, and it's a very difficult area, but I think that biochemist, they're happy to talk to you, and I can talk to you later too.
Thank you.
We'll go over this side.
Hi, I'm Catherine, a GP from Perth. My question is regarding the AndroFort versus the AndroFem being equivalent products.
There was a little error there. AndroFort is a 5% testosterone cream, so the blue one for the boys is 5%, the pink one for the girls is 1%.
Okay, but they are actually equivalent products, just a pink and blue, like in terms of, apart from the concentration.
It's the same testosterone, it's just a 5% versus a 1%.
So the pink one, just having a quick look on the Chemist Warehouse, is almost equivalent pricing to the 5% blue one. So are you able to then use, I'm assuming then we can use, say, 0.2 mils of the blue one and get the equivalent dosing as 1 mil
I'm going
of
to
the
be
pink
bossy here and be an Australian, I'm so sorry, but I do not like to use the 5% in my women. Some of them have been very bossy and have said, I want that script, I want it to be cost effective. Their levels have gone super physiological, and I will not use it unless there's a very good reason. There is a beautiful product, AndroFem, it's pink, it's white, it's in a tube. If they want to have this boutique treatment, they will get that product from me.
So why do you think the physiological levels differ? Is it because it's too difficult to draw up?
It is very hard to use. It's too hard to use that.
Because it just seems like there's a pink tax.
Wasn't the other point in the slides?
Yeah.
I think there is a beautiful product here, pink and white. Start with 0.5 ml a day, do the levels after 3 to 4 weeks, and just be safe.
Thanks.
Thank you. We'll go over here now.
Hello, Irina, GP from Melbourne. In the slide with possible side effects and contraindications, it said testosterone doesn't increase your risk of VTE, so is then VTE contraindication to using previous VTE? Because on the prior slide to that, it said the past history of VTE is a contraindication to using testosterone.
What was the question?
So
That
I think the
VTE.
question is,
VTE.
even it is listed as is it a contraindication to have a prior history of VTE, even though the data suggests it doesn't increase VTE? So that clarifying that question.
So as it relates to VTE, not all VTEs are equivalent, and recognize that there may be underlying non-modifiable causes of VTE. So to the degree that you can, try and figure out what the cause of the VTE is in the first place. Those that are modifiable, like not flying to Australia in 15 hours, that might be modifiable. Try and do what you can to figure out if this is a reproducible cause of her VTE, and I'd be much more careful. But in general, non-oral steroid hormone delivery does not present an added risk of VTE. Just saying.
So there are theoretical risks of excess testosterone use that are different than what happens when a woman is given a physiologic range dose, and I think this is one of those areas, right? The theoretical risk of increasing the hemoglobin, liver enzymes, thromboembolic effects. But if you use it the way we're recommending, then we don't see those clinically. We see the main things you see in range potentially are a small number get acne and hirsutism, and you can work with the dosing. Something I realized I didn't say very specifically, and I mentioned to Dr. Davison, why would you go up of the 0.25 mLs at your 3 to 6 week evaluation, or your 6 month, your 3 month and 6 month and 12 month evaluations. It's that they're not exceeding the reproductive range that we're recommending, and their symptoms still aren't better, right? Right, so if someone their levels, it doesn't matter what it is if their symptoms are better, even if it's the placebo effect, but you might want to go up as long as you're not exceeding the recommended level to a maximum of 1 ml. I think that's an important point to make.
One more point that relevant to the VTE story. So these were not men that had prior VTE, but men given testosterone in the Traverse trial related and had levels of testosterone approximately 300 nanograms per milliliter, 8 times to 10 times the normal female range, did not have an increase in VTE. Transdermal, non-oral testosterone.
Dr. Islam has produced a beautiful meta-analysis. We're so lucky to have him in Melbourne, and I'm delighted to have his question. Thank you.
Thank you very much, and great presentation, great panel. And we're really lucky that testosterone is approved in Australia. And my question to James, that as you said, both men and women could be sexually active up to 80 years, 90 years. So my question is, how long testosterone could be used? 10 years? Or 20 years?
It's so nice to see you in person.
How many years testosterone could be used?
Can you use testosterone until you're 90, or do you just use it from 50 to 55? Is that your question?
I'll tell you what my favorite gynecologist is.
I mean, if someone is like starting at the age of 55 years, and then how many years can continue?
Until 3 days before you die, maybe? I think the answer is that we don't have safety data in randomized trials beyond the point that you're very familiar with, and that with extension trial of even up to 4 years, we saw good safety in intermediate cardiovascular endpoints, endometrial and breast safety. We don't have the data beyond that time frame, but it's reasonable as long as you're doing the clinical surveillance I mentioned and an informed consent, risk-benefit conversation with shared decision-making to continue as the woman wishes. And although we need data, we don't know what happens over time with safety. We also don't know whether there's any impact if you stop it on that neuroplasticity of the brain, that you suddenly don't need it anymore. And if the woman wants to try to stop it, usually they come back and ask to restart. Dr. Simon probably will say the same thing. So that's the best answer I can give you.
A week before they die.
I'll go over. We'll just take these last 4 questions, so please have
Jane Offer, local GP from here with an interest in sexual medicine. I see quite a few women with vulvodynia, and anyone who's treated vulvodynia will realise it's a very complex problem requiring multiple different levels of intervention. I was very interested to hear what you said about the vestibule being an androgen-dependent area, and wondered, is anybody looking at the addition of topical testosterone to the vestibule as a part of a treatment program for people who have treatment-resistant or difficult to manage vulvodynia?
Yeah, so the papers that I referenced in my talk summarize the literature, world literature on the use of androgens in hormone-mediated vulvodynia, vestibulodynia, and it clearly works, and there is one randomized non-placebo, but randomized clinical trial of estrogen alone, topical, versus estrogen and androgen, showing preference in the outcomes in hormone-mediated vestibulodynia to estrogen and androgen.
And how do you know which women? I mean, when you say hormone-mediated, okay, you see the menopausal women.
Yeah.
But for women at all age, you mentioned that some women have varying degrees of androgen insensitivity.
Yeah.
So is it applicable in a broader sense, not just for women with, with menopause-related vulvodynia? So I'm thinking of, younger women that I might have seen who have got, inadequate response to all of the other interventions.
Yeah, so the data is very clear on premenopausal women. Typically, the typical patient would be a woman who's been on androgen deprivation or on long-term hormonal contraceptives with an anti-androgenic effect. They have hormone-mediated vestibulodynia, and if you take them off their birth control pills and they don't get better on their own, the treatment that I just recommended with an androgenic topical combination, steroid, estrogen, testosterone, or just testosterone, will help most of them. And there's data for all that.
The current formulation of such as Androphene, would be a suitable product to use?
Oh my goodness, that's a good question. I don't believe it's been done. We do not have Androphene in the US, much to my disappointment, but maybe someday. And we use compounded therapy in that setting because we don't have a choice. But maybe you can try it and get back to Lolly and tell them how it worked.
Yeah, I think it's...
I mean, it's not a current indication, but... But remember, the compounded product that we're using in the US and I think elsewhere is not achieving systemic levels. It's very much a local delivery. So you're talking about local delivery of Androphene, which has not been tested, and it's not an indication. But as Dr. Simon said, could be.
Could be.
Hand over to here now. Thanks.
Doja Jordan from South Africa. I just wanted to ask for the specific patient with hyperactive sexual disorder who is on an SSRI for anxiety. So not depression, anxiety. If she has a low testosterone, would you keep her on the same SSRI and give her the testosterone, or would you be looking at changing the SSRI first? And if so, which SSRI?
So this is a great question. I'd love to do a whole topic or a whole seminar on this, but a few comments. So I think when you're looking at an SSRI and its sexual side effects, it's identical for treatment-emergent side effects for both the indication of anxiety and depression, which are both approved indications. And one of the things I said was that the best thing for a person's desire is to make sure they're not depressed. And sometimes that means using pharmacotherapy. If you develop treatment-emergent sexual dysfunction that includes low desire from either an indication of anxiety or depression, it's a decision. So if that medication is working so well for that patient that using something different isn't something she wants to do, or the clinician who's treating thinks is a good idea, you've addressed the modifiable factor in that you're not modifying it. And that's an important point. If you're not going to modify it, you can still go forward with using testosterone. The person might also say, hey, you know what? I'm not wedded to this. I'm willing to try a different one. I'm going to make that change and see before I initiate using testosterone, even if all the other things line up for using it. There are a collection of medications. The effect on SSRIs and SNRIs are slightly different if you look at data drug for drug, but it is a class effect. It runs about 30 to 40%, even if you improve the symptoms of anxiety and depression or give them remission. But there are some that are better. I'll mention a few. They're usually more the atypical ones. So, bupropion as either an add-on, which is a solution for anorgasmia, or as an independent switchover, vortioxetine, vilazodone, desvenlafaxine, and maybe mirtazapine. So those are the 5 that have been reported in discussions in the literature.
Yeah, and I also think, particularly with Dr. Islam here and Dr. Davison, there's a little mini shout out to Dr. Flutie, isn't it? From Dr. Davis's group in premenopausal women used testosterone in SSRI-induced sexual dysfunction with a positive effect, although it's small trial, small positive effect, but it was in the right direction. So maybe for that patient, it's another option in addition to what Dr. Parish suggests.
So it reinforces the idea that if you're not going to modify it, you say just to keep it for all the reasons that are good, that they're doing well in that therapy, you can add on testosterone. That study happened to be premenopausal women, which speaks to a whole different question about whether SSRIs alter hormone activity, testosterone hormone activity at the level of the brain receptor. Because these, again, were I think they might have been late reproductive age, but that's not the point.
I'm so sorry. I've been told we do have to wrap up. The last 2 questions, if we could have them after this. Thank you so much for attending this session. Scan the QR code if you want a recording of this. Thank you so much to the sponsors of the session and to our amazing speakers. And to those last two questions, find us. Okay, I'm so sorry.